Dear dental colleagues, my name is Emanuele Clozza and I'm an implant dentist based in London. I'm excited to share with you my experience with a novel photogrammetry system called Tupel3D, manufactured here in the United Kingdom. This presentation is a result of a clinical experience developed over 1,200 full arch implant restorations completed since 2010 with 1,000 interim and definitive prostheses delivered with conventional methods, and more recently around 200 arches with fully digital protocol. We have seen a shift from conventional techniques to digital protocol in complete arch implant restorations, specifically in planning the case, in carrying out the surgery, in taking the impressions, in fabricating the interim and definitive prostheses, and in obtaining occlusal and facial records. What I'd like to focus today is on capturing the implant position. Conventionally, we'll take analog impressions, and now with digital techniques, we can use intraoral scanning and photogrammetry. The way we conventionally take full arch implant impression is with an open tray, a rigid splint, and a polyether or PVS impression material. This technique is well recognized in the scientific literature, and it's very important to have a rigid splint because otherwise the presence of the marginal discrepancies can lead to biologic and mechanical complications. This is a full arch that I completed more than 10 years ago, fixed level, and you can imagine just to take off the interim prosthesis at each appointment, it would take me 15 minutes. Then you need to take the first impressions, in this case with a chair-side resin jig, then a second impression with custom abutments, followed by a few other appointments for the verification jig, the metal try-in, the bisque try-in, and then delivery of the definitive prosthesis if everything goes well. And this is the outcome that is acceptable for the specific case. What we're doing nowadays is the conventional impressions for full arch implant restoration on a multi-unit abutment level, and you can see here we fit the impression copings and we link them with some pattern resin, and then we utilize PVS or polyether impression material. The next, what you need to do is to request a stone verification device from your dental lab, and then take an X-ray to confirm the seating, and if the stone verification fractures, then the definitive prosthesis is not accurate, which means that you need to reconnect the parts with plaster of Paris and send back to the dental lab. And then another conventional method in full arch implant restoration is the intraoral conversion or pickup, which can be done with pattern resin or with acrylic resin. And then you can see here a case of post-surgery. We'll fit titanium cylinders and then utilize a prefabricated denture, and then basically block them with some resin, and then remove the palate, reinforce with a metal bar, and then polish it, and then fit on the patient's mouth the same day of surgery. What now we are utilizing is intraoral scanning for full arch implant restorations, and then at the moment I'm comfortable utilizing this method for initial situations, and then for existing interim prosthesis. However, I cannot use this scanner alone for post-surgery and for implant impressions for definitive prosthesis. There are several intraoral scanners in the market, and then also each implant company has introduced its own scan post with different material, size, and geometry. So you can imagine how challenging it is to obtain some repeatable and predictable results. And this is a very interesting study that was carried out in ideal conditions. So this group of dentists tested 5 different types of intraoral scanners that are available in the market, and then they tested in 3 clinical situations. So for restoration of single implant, restoration of a small 3-4 unit bridge, and then for the restoration of a full arch implant restoration. There are two take-home messages with this study. One is that different scanners can generate different deviations, and also deviation are acceptable clinically for single implants, and then for 2-3 unit bridge or 4 unit bridges. However, when it comes to full arch implant restoration, you're going to achieve a higher deviation. Okay, so at the moment we are comfortable scanning intraorally for 3-4 unit implant restorations, and then if there's any inaccuracy, worst case scenario, we just need to adjust the interproximal contact or the occlusion. But when it comes to full arch implant restorations, there are some intrinsic limitation with the intraoral scanning alone, because of the instability of the soft tissues, so especially when there's no keratized tissue, and also there's a lack of landmarks in a maxilla, in a mandible, in a dental patient, and also the floor of the mouth movements, the patient movement, and also the increased distance affects the overall accuracy of the scanning. We know from literature that the tolerance is for around 10 to 150 micron is acceptable for definitive passive fit. However, if we have more than the 150, you can end up with a misfit. Okay, so again, the deviation that are smaller than 50 micron are negligible, because we know that in full arch implant restorations we work at the micron level. So 1 millimeter is 1000 micron, and in full arch implant restoration, really a clinical acceptable fit should have a deviation of less than 100 microns. Let's look at the recent systematic reviews. You can see there are a lot of preclinical studies that basically compare digital and conventional techniques, and then the conclusion was quite interesting, is that the type of intraoral scanning technique, and the environmental conditions, the angle, the distance between implants, the material of the scan bodies, all can affect the accuracy of the intraoral scanner. And we know also from daily clinical activity that intraoral scanning alone is not really reliable for a complete arch implant impression, especially for post-surgery, because of the bleeding, the saliva, and then when you want to retract the cheek, you get more bleeding, more saliva, and on the mandibular arch, it's always challenging, and then also when you have more than 4 implants. Right, so there are researchers that have joined the race in trying to find a method that can allow us to obtain accurate implant position for the fabrication of definitive prosthesis. And then you can see here are basically put together all the articles that have been published recently. There are really different strategies. Could be the CT scan, a verification jig, and scan analogs. Then we have scannable impression pins, anchor pins, and then more recently, additively manufactured devices. Okay, the issue is that really all these methods are not really applicable for the fabrication of an interim prosthesis. Okay, what I now believe and utilize is the dental photogrammetry for full arch implant restoration, and I believe this is a sort of transformative innovation, because it is a digital auxiliary tool to capture the exact position of the implants. And in particular with Tupel3D, there are some innovative features, which is it is wireless, it is battery powered, there's a built-in LCD monitor, the calibration takes 30 seconds and it lasts 3 hours. It is portable, lightweight, it has a single travel-friendly case, which is in total weight less than 3 kilos. It is compatible with any CAD/CAM design software. It is open platform, free software, and has a competitive price. Okay. Moreover, the narrow camera separation allows more reliable capture post at the back in the mouth, especially if you do pterygoid implants. And also there's some innovative feature in the scan post or scan dots itself, which are designed to be connected on the multi abutments, and they are easy to position by hand. And then there's because they have a smaller targets, they require high resolution cameras, and then they provide better immunity to disturbances such as saliva and blood. Also, there are more targets compared to the other systems within the post surface, and the targets are very, very close to the implant axis with an excellent absolute accuracy in ideal conditions. Okay, and I'm going to show you how it works. So if you compare with the intraoral scanning, so the device, it is basically an extraoral scanner that can capture the exact position of the implant only, so disregard all the soft tissue, because the soft tissue will be captured by the intraoral scanner. Okay, and then when you obtain the photogrammetry data, and you can see that you have basically just the position of the implants, okay, floating in air, and then this accuracy of the position of the implant is less than 10 micron. Then what you do is to basically align the photogrammetry data with the intraoral scanning, and then you can then construct a very passive final implant bridge. Okay. The photogrammetry is a well-established procedure now. There's a systematic review that has reviewed more than 20 articles, and I think now there are even more than that. They're all claiming that we can achieve a successful prosthesis fit, and it is a valid and reliable clinical tool for implant dentistry. Most recently, the photogrammetry has been we demonstrated that it is more feasible than intraoral scanning alone for complete arch digital impressions in vitro and also in a clinical study. Okay. Right, so now let's discuss how we can integrate and utilize the photogrammetry in a digital workflow for a complete arch implant restoration. And then this is something that I've tried to answer in a scientific article, and you can find this article in a clinical advance in periodontics, which describes basically the workflow for full arch implant restorations. And now I'm going to show you a couple of clinical cases. So this is a case, a fully digital FP1 complete full arch rehabilitation with the initial 3D printed interim prosthesis, which is going to be scanned, and then next we remove the interim prosthesis, we fit the scan bodies, and then we scan the implants and the soft tissue. The next we then position the dots post onto the multi abutments, and then we perform a scanning with the photogrammetry, and then you can change the geometry to your desired scan body. So basically we have intraoral scanning data, so we have the existing interim prosthesis, the opposing arch and the bite, and then combined with the impressions, the scanner of the arch or the implants, plus the photogrammetry data. Okay, and then what you can do yourself, you can or the technician can do the alignment with any CAD/CAM software. So in the case can be done with MediDesign or by your technician with Exocad. That's quite easy. Okay, and then next you have to then detect the implant position, and then proceed with the design of the definitive prosthesis. Okay, and this is the case completed with a zirconium bridge, titanium reinforced, and then you can see here from the control x-rays an excellent passivity of the prosthesis. Okay, so there's no gaps, and also clinically the feel is that the bridge itself is very passive. Okay, Now I'm going to show you another case on the lower arch, and that's basically a surgical case. So failing dentition on the lower arch, teeth are extracted, and then we do an intraoral scanning, and you can see here how complex it is to do an intraoral scanning on post-surgery. Then we do photogrammetry, and then once the data are aligned and combined, then we basically do a digital pickup of the to basically achieve the vertical dimension, and then to also the centigrade. Okay, so basically this is a 3D printed pickup denture that then has been basically locked in, stabilized with some indexing material onto the scan bodies. And then 3 months after, we basically scan a 3D printed interim prosthesis. We scan the opposing arch, we scan the bite, and then again we scan the soft tissue, but this time we just do the intraoral scanning. There's no need of redo the photogrammetry. And that's basically the day of the final fit. So then the prosthesis, you can see, fits nicely, passive, and the case was completed with a PMA titanium bar definitive bridge. Okay, in this way, in this technique, and with this scanner, I completed more than 200 arches, interim and definitive prosthesis. Okay, right, now let's discuss the evolution when it comes to prosthesis. So in a conventional way, we would do cast framework, acrylic resin with denture teeth, and now we are shifting towards CAD/CAM restoration. Okay, this is the conventional way that more than 10 years ago I used to do full arch implant restoration FP3, so with a heat cured PMA titanium bar hybrid definitive prosthesis. And now we have available CAD/CAM prosthesis, okay, which can be done with a subtractive method, so milling, or with additive method, 3D printing. When it comes to mill interim prosthesis, so if we do conventional impressions, we then you basically have to cement titanium cylinders, but as you can imagine, that also lead to less accuracy. But nowadays, because of photogrammetry, because we are able to mill PMA interim prosthesis designed to fit directly into the multi-unit abutments, and that can reduce cost and simplify the process. Okay, there's been also an evolution for the metal framework. So originally we used to do cast alloy framework, and now we have much more sophisticated advanced CAD/CAM framework in titanium. And then we know that the mill titanium bars are much more accurate than the cast alloy. Okay, and this is the typical FP3 mill final restoration that I usually offer to my patients. Okay, and then we can also have mill FP3 zirconium definitive prosthesis. Okay, all right, so now let's talk about FP1 interim prosthesis. Okay, and the conventional way that we do is to basically, we can plan the case digitally with a surgical guide, and then we can have a technician on site and then feed the cylinders and do what we call a pickup technique with titanium cylinders. Whereas nowadays we do in a fully digital way with a dental technician in the lab that can basically design on the same day and fabricate and print an interim prosthesis. Okay, so there's no need of components. Now I'm going to show you a case done in a conventional way. So FP1, upper and lower arch. So initially we plan the case on a CT scan just to position the implants, and then we then align with the initial intraoral scanning, and then go ahead with the design of the interim prosthesis and then surgical guide. And then the day of surgery with stackable guides, then we remove the remaining teeth, we place the implants, and then basically we connect the titanium cylinders into the interim prosthesis, and you can imagine how fiddly and complex is that, and also sometimes there's too much pressure on the soft tissue, and then that can cause misfit, as in this case, and then also takes a lot of time. I remember I fit these bridges around 10 in the evening, and then after the X-ray I could see there was a misfit, so then I have to basically remove the prosthesis and then adjust the pontic and then refit, and that's the case completed. So it is possible, but however it is quite complex, and then there's a lot of risk of complications. So nowadays we are now available 3D printing, which are not only able to give us, you know, definitive models or pickup dentures or models, but also FP3, FP1 interim prosthesis, okay, and they are extremely aesthetic. Here's another example of how it's designed and then printed an interim prosthesis, okay. It's very important to understand the factors to control in FP1 restoration. So we need to do 99% guided surgery, okay. Also we need to be able to control the quality of the soft tissue available in front of the multi-unit abutments, and also dictate the design of the merging profile and also the pontic, okay. And when it comes to FP1, especially in the aesthetic zone, it's very important that we understand what's the ideal position of the implant, also the ideal size and angulation of the multi-unit abutments, because otherwise that could lead to anesthetic results, okay. In addition to that, we need to also understand the quality of the tissue available. So 2 millimeter at least of soft tissue thickness should be available facially to the final restoration, and so it means that the majority of the cases I do now require a surgical addition of soft tissue graft, okay, to obtain what we call a prosthetic seal graft once the interim prosthesis is fitted. Now I'm going to show you a case, the way I basically do FP1 now. So I do an initial plan on a CT scan, and then I superimpose the CT scan with the initial intraoral scanning. The technician in the meantime then will do a design of the interim prosthesis, which will be then superimposed with the initial CT scan. So then I can basically check the position of the implant, and I can correct, and then next the technician will fabricate a surgical guide, and then I'll then proceed placing the stacking the teeth, doing the bone grafting, the socket preservation procedure, the connective tissue graft, then place the implant, suture and fit the multi-unit abutments, and then with the digital pickup denture then obtain the vertical dimension, the centigrade, then next scan a soft tissue with an intraoral scanner, then photogrammetry, and this is the type of interim prosthesis I'm able to design and then print on the same day of surgery, okay. So it's very important. The way I do now is basically guide my technician to basically create an adequate pontic surface, inadequate emerging profile, okay. And then you can see here how basically with the interim restoration we're able to address the majority of the issue that were present in the initial situation. So we're able to correct the occlusal planes, the midline, and then obtain an adequate fit of the prosthesis and also guide the soft tissue, okay. It's very important to familiarize with the emergent profile concept, which is a transmucal area between the implant shoulder and the mucosal margin. And so we are now we have classic literature now that is able to explain the concept of a subcritical and then a critical contour. And also we have to, as a dentist, be able to design and understand the concept of inadequate pontic, okay. The gold standard pontic is an ovate pontic, and then the is very important, especially in aesthetic zone, because it develops, supports, and maintains the gingival texture where the tooth is missing. Okay, and also there are some articles recently that are suggesting more sophisticated, design of the pontic. Okay, and also it's very important to modulate the degree of pressure on the mucosa, whether it's on a post-surgery or on a heel ridge, like in this case. Okay, I'm gonna show another case now. 3 months after surgery, we then do data acquisition and intraoral scanning for us, and then photogrammetry. And these are the type of interim prosthesis I'm able to fit just 3 months after surgery. And then you can see how I have a first set of interim prosthesis right after surgery, which I keep 3 months, and then once the implants are fully integrated, then I provide a second set of interim prosthesis that can basically improve the shape of the fitting surface. Okay, so then when I fit the definitive prosthesis, I know there's not excessive pressure on the mucosa. Okay, and as is the case completed with a titanium reinforced mil zirconia on the maxilla and a mil PMA on the mandible. And this is the case finalized. You can see there's complete passivity of the prosthesis. Okay, and this is quite a big arch that's been restored. Right, to conclude my presentation, there's a clear difference between traditional analog techniques and then a fully digital workflow. Traditionally, we require at least 8 visits to complete a case, okay, with long appointments required, whereas now with fully digital workflow, we can complete cases in 5, 6, or even 4 visits, okay? So we have the consultation, the initial planning, and then the day of surgery, we can choose whether we do a pickup denture or usually utilize digital techniques such as intraoral scanning and photogrammetry. And then 3 months after, you can see with the digital methods, we can skip at least 2 visits, okay? Because in a conventional way, we have to do a verification jig and then a metal bar train, whereas with intraoral scanning, we can just skip that, and also with photogrammetry, and then we're able to deliver the definitive prosthesis in a very timely fashion. Okay, with this, I would like to thank you very much for your attention, and then if you're interested in seeing more cases, more advancements with or then also keep updated with our Tupel scanner, please follow us on Digident Ltd account, Instagram, or Dr. Klossa. Okay, thank you very much.